So Dr. Bavare is one of our favorite vascular surgeons here at Methodist, and he's going to be talking about TEVAR.
Hi, good morning. I'm Charu Bavare. I'm one of the only vascular, not cardiovascular. So I'm sitting in August's company back there. And these are the people actually who have trained me in the past, Dr. Reardon, and then now getting more training from Ross and Tom, and a great group to work with. But the mouse is not good to work with, yeah? Oh, there it is. Okay, so my topic is TEVAR, and I mean, I'm like taking a big bite to chew because we have experts sitting in the back out there. I'm just going to talk about what I know a little bit about. So we'll talk about the history of TEVAR, a little why we do it, what's the pre-procedure planning, what imaging is involved, what do we do at the procedure, how do we follow these up. We have some newer, more exotic and bleep indications, and then some conclusions of what to do or what not to do. The indications, the most common indication is thoracic or descending thoracic aortic aneurysm, traumatic aortic transection, which is a grade 2, 3, or 4, type B aortic dissection, penetrating aortic ulcer, intramural hematoma, and then the thoracoabdominal aortic aneurysm. Usually it's a multi-component complex repair, not just a single graft, right? There is a lot of pre-case planning that goes in because one, endovascular therapy has dramatically decreased the number of people that can be, number of people that can be offered treatment now. So someone who will probably code with a haircut will probably do okay with a little local and putting in a graft up their aorta sometimes. Straightforward cases can actually just be that. Sometimes they are pretty straightforward if you choose them wisely. Difficult cases can be disasters, of course, and make sure we anticipate potential complications. Access issues, need for the conduit, patient comorbidities, cardiac comorbidities, stroke comorbidity, etc. And then risk of paraplegia is a finite complication of this procedure. So with prior aortic surgery or a left subclavian artery origin involvement and coverage of that, chronically occluded the internal iliac arteries, and then coverage of T12 to L1 segment of the aorta where the intercostals come off. And we'll come to that as well. I don't see these images up here. Anyway, it's increasingly important with complex cases to be prepared for this. You need proper imaging systems because you cannot see you cannot fix what you cannot see. You need a lot of array of wires and catheters and adjunctive things on your repertoire. You need the OR. We don't have the cath lab. We usually have an OR crew which is pretty capable of doing this with us. Some facilities bring the OR and cath lab together. I think that's a paradigm with the TEVARs for sure. You need to be skilled for this. It's not a chip shot every single time. So we have to have maneuvers to get ourselves out of trouble as well. Plan for whether you need to revascularize the left subclavian artery or not, and there are specific indications. And then perioperative spinal drainage is like the absolute standard now of care. The anatomic issues involving suitability, right? So you have to have a proximal and distal length of more than 20 millimeters, at least for a landing zone in the thoracic aorta. There shouldn't be a lot of aortic, if there is a lot of aortic thrombus, the seal may be an issue. Access sites are always a problem. You need a big sheath to go in with a big device, so an access vessel of at least 7 to 8 millimeters is needed. Sometimes you may need to put a conduit. There could be occlusive disease in those vessels. There is a lot of tortuosity sometimes in the iliac arteries. There could be concomitant common femoral disease, so you might need to repair the femoral artery and then put something through. And you need, I don't think it's 25%, it's less now with the smaller caliber, low profile devices, but you may need to do an iliac conduit to get your device in sometimes. The tortuosity of the aorta itself could be a problem, and then the cerebral arteries coming off the aorta going into the circle of Willis could determine your stroke rate post-procedure. More often than not, we've almost always had, almost surely nowadays do percutaneous access with pre-close technique, but you may have to do an occasional cut down in the end or even in the beginning as a planned procedure. Some surgeons actually prefer to do a cut down to begin with, so you have control on the vessel. It's not wrong, it's just preference sometimes. It just makes it easier afterwards. Consider a conduit, like if you're doing a large device, so therefore you need larger access in the artery. Then open iliac conduit is usually a 10 millimeter graft with a retroperitoneal exposure, and that gives you enough length to go through and intervene on pretty much all kind of device sizes. Sometimes we have an endoconduit with a stent graft placed inside the artery through which you can go through. That is if the artery is very calcified and you might need to intervene. Imaging is the key, where you have to have a sure shot, good quality cross-sectional image. You may not have all the other tools like the M2S, Terraricon, Osiris, but we have to know what's the right angle. We have to know what's the right length. You have to make sure the tortuosity is taken out. I don't personally use the M2S system, but some people swear by it. These are good tools to have if you do, but if you don't, it's not the end of the world. But if you can, it'll make life a lot simpler for planning. So proximal zone, distal landing zone, and I cannot see that. So based on the CAT scan, this is all made nice and fancy for us, right? Keep in mind, sometimes tortuosity of the vessels, you don't see much in the axial, but if you have a reconstruction, you'll see it much more. Using an IVUS is really, really crucial, almost like standard of care in thoracic dissections, where you have to know whether you're in a true lumen or not. Otherwise, a TEVAR can just make a good case into a great case. So you have precise measure. So you have to precisely measure the aortic diameter and length, make sure you're in the true lumen, especially in trauma or ruptures, iliac axis, origin of the arch vessels, visceral vessels. It takes a little training for the eye to look at and interpret an IVUS, but with experience, actually it's a solid tool to have and to know. So usually this is for an aortic aneurysm, right? So you have bilateral common femoral axis. You do an arch aortogram. Make sure that it's an LAO projection because the arch goes back and to the left. It doesn't go this way. So make sure the II is angled properly. Anticoagulation is something I routinely use on all these endovascular devices because you have huge sheaths going up in the iliac. So you're almost completely occlusive at that point. Curved Lunderquist wire is the workhorse for a TEVAR, which is a pretty stiff, we call it the coat hanger wire. I've stole one for my wardrobe as well. Use the IVUS when you have to have it. Stent graft deployment, usually on the way out sometimes for a iliac on a stick situation that you might have, hopefully not. And then post-implantation, post-dilation, use that with caution in cases and use it never in dissections. Remember this, the word is never. Never say never, but never dilate in a dissection because it will turn a good case into a great case. So a case example is a 69-year-old guy who's got, where'd that go? He has an aortic aneurysm about 4 centimeters, but he's getting bigger now. He's got severe hypertension. He comes in with this is not my slide, but typically this is a great illustration of how to measure these things and how to plan for this. So you look at the proximal landing zone, distal landing zone. This looks like almost like a type 3 arch where all the great vessels come off below and it still keeps going higher. Look at the distal landing zone, look at the calcium, and it gives you a lot of clue. So the planning here is, I trained here, and then Alan Lumsden, our chairman, he used to tell me, or he still tells me actually, that nothing of what you do for an endovascular case should be a surprise in the operating room. So you have to plan for this. You should rarely have anything that's going to be oh, I didn't see this before, because we see a lot of things on CAT scan now. So planning. Usually TEVAR patients can be actually discharged the first or second day, and then they get a 3D CT within 30 days of the procedure. Typically you don't have to repeat it for about a year almost if you have a good result, because endoleaks is something that you don't actually get too often in TEVARs. In EVARs, it's a big bane of our existence for sure. Pitfalls, so sizing errors, undersizing, oversizing can have serious problems. Insufficient length or quality of the fixation zones, not placing the endograft proximally enough can be a problem. And then sometimes there is reluctance to go right up to the origin of the subclavian, or even say, okay, I'm going to cover it and then revascularize it, right? So it takes about half an hour more for the procedure. But we have seen patients who've not had this done because the surgeon didn't want to add some time. That's bad. Make sure you anticipate all your access problems, because access side problems are the case goes great, but then the access side becomes a big issue afterwards. A bird's beak is where the aorta is pretty angled up, pretty quick, acutely, and then the bottom portion of the stent graft doesn't oppose to the aorta, so it remains this way. And then over a period of time, this can have a leak, a type 1 endoleak, or the aorta can get compressed around that, so that becomes a problem. Great vessel involvement in thoracoabdominal, or thoracic and abdominal or aortic aneurysms. Typically, you don't have to revascularize the subclavian artery, not routinely. You can get away with that, especially in trauma. We can cover it and get away with it. The problem is here. There is an absolute need in these conditions. So you have a patent Lima bypass. Every cardiac surgeon in the hospital will come after my neck if I do this. I actually might go after my neck first, but if you have a patent Lima bypass, you have to revascularize subclavian artery. If you have a dominant left vertebral artery, you have to revascularize. If you have a left vertebral artery which terminates in the brain and then the right vertebral is dominant, then remember, even though the right vertebral is dominant, you still need to revascularize the left subclavian. If the left vertebral comes off the aortic arch, it's not an absolute contraindication, it's absolute indication. If you have a stenotic vertebral artery, if you have a fistula, a dialysis access, again, I wouldn't say this is absolute, because you can always have a catheter and go for a new fistula on the other side. That's not life or death, but if you're doing a life-saving operation, that fistula may not be the only thing to do. So a carotid subclavian bypass, usually with prosthetic material, or you can transpose the subclavian artery. It's easier said than done, because you have to dive in a hole, make sure the vertebral Lima come off, and then take the subclavian off there. The zone 1 arch involvement, which is right at the takeoff of the left subclavian, you may need to do a carotid subclavian bypass and then cover the whole portion there. Sometimes you need a lot of hybrid procedures where we actually work really well with the cardiac surgeons at our hospital, where we do a debranching from the ascending and then cover the rest with a good landing zone there. Now with new endografts coming in the market, you can actually have branch devices. You can have a branch going up into the subclavian artery, so that negates the need for a carotid subclavian bypass. They're all complete systems. Gore actually is the only one right now who has an FDA-approved device. I'm sure there are multiple people in the market coming up with something more. So this is one tool to know and how to use. Big complications to remember are stroke, paraplegia, visceral ischemia, migration of the device, and then access site complications. So analysis of stroke, it's pretty significant. It's about anywhere between 5 and 25% of the time. And typically it's where the zone 1 aortic arch is involved, where you have severe athermatous disease in the aorta, and where you cover the left subclavian artery. The neurologic complications from the Eurostar registry, actually it's about 0 to 6% in TEVAR, but it's about 12 to 14% in open. And if you have a prior history of infrarenal aortic repair or replacement, if you cover more than 20%, I'm talking about spinal ischemia, I'm so sorry. So if you have, incidence in TEVAR for spinal ischemia is about 0 to 6%, and open surgical procedures up to 14 to 20% actually. And if you have a prior history of infrarenal aortic repair or replacement, because you knock those collaterals off, if you cover more than 20 centimeters of the descending thoracic aorta, if you use more than 3 stent grafts, which is obviously more than 20 centimeters, and if you cover the left subclavian artery, if you have an occluded internal iliac artery, that your risk of paraplegia goes high. And the logic is here. The vertebral arteries go and meet the basilar artery. Before they meet the basilar artery, they send 2 arteries down, which becomes the anterior spinal artery. That's one critical artery for the brain, for the spinal cord proximally. The next big one is the intercostals coming off, and the artery of Adamkiewicz coming off at about T12, L1 level. So coverage of all that aortic segment can become a risk for spinal ischemia. This is a great paper actually from the anesthesia and analgesia, which I never expected there, but and I feel kind of sorry we didn't come up with this thing. But I think Dr. Athanasiou will talk more about that. Essentially, you want to keep the spinal cord perfusion pressure right. And so you maintain the MAP, you keep their CSF pressure low, make sure you give them fluid boluses, make sure you resuscitate them properly, supplemental oxygen. That's the 4 things, and obviously Dr. Athanasiou will tell you more about that. Follow-up is we do CTA per protocol about yearly and then every 2 to 3 years. Endoleaks are really less common than EVAR, and then secondary interventions are few, except for the bird beaking, which becomes really bad. I would say endovascular therapy has dramatically expanded treatment options now for people who erstwhile would have been bad candidates for descending aortic problems. Evolving technology and refinement of skill set of physicians will help gain more access to these cases. I did not go into the branched endografts and all the fancy fenestrated stuff that we do, because I think just basic TEVAR is what this involves. And then remember, perioperative stroke and perioperative paraplegia will remain the main complications to watch out for. And I thank you so much.